Hello everyone, my name is Andrea. Thank you for watching my presentation. So today we have Mrs. BC. So Mrs. BC is a 65-year-old female that comes to the clinic with her husband. And she is a reliable historian and is able to provide information about her signs and symptoms and her past medical issues. So a patient that's come with a chief complaint of my knees hurt a lot. She reports that the pain has been severe on both knees, mainly worsening at nighttime for the past 6 months. She also describes the pain as aching and sometimes grinding. There is mild swelling on the right knee and a stiffness lasting for 10 to 15 minutes in the morning. She also states that it worsens with prolonged sitting. It is relieved by rest. She's tried Tylenol over the counter, but there is not much relief with that. She also complained that the pain has started affecting her activities of daily living, yet she still remains pretty independent. So past medical history for this patient is hyperlipidemia, hypertension, CKD, COPD, and type 2 diabetes. Her past medical surgical history is going to be right ACL and meniscus reconstruction at 20 years of age. Her medications are metformin, glyburide, pravastatin, amlodipine, and albuterol. Her social history, so patient does live with her husband. She's a former smoker. She stopped smoking about 10 years ago. There is no alcohol or recreational drug use, or she also lives a sedentary lifestyle that is high in diet and large portions. She has no past medical allergies or to food, latex, or medications. Vital signs, her height is 5 feet 6 inches. Her weight is 200 pounds. She is 32.3 on her BMI, so she's considered obese. Her blood pressure is 155/95. Her heart rate is 90, and her respirations are 15. Temperature is 98.9, and oxygenation is 96% on room air. On her physical examination, patient is alert-oriented. She communicates very well and has a steady ambulation. Respiratory-wise, there is some mild respiratory wheezing, but there is no exceptional dyspnea. Cardiovascular, her heart rate is normal. There is no gallops, no rubs, or no murmurs. Musculoskeletal patient does have some mild swelling, tenderness along the medial joint lines bilaterally, which worsens at nighttime, and crepitus are noted on both knees. She also still has full range of motion, but you can see there is some stiffness on both knees. There is also mild effusion on the right knee, that more than the left one, and there is presence of Heberner's nose and mild thumb base squaring. So the primary diagnosis for this patient is going to be osteoarthritis, because it's most likely based on the bilateral knee pain, stiffness, and also the crepitance in joint line tenderness. Also, I chose this primary diagnosis for this patient because of her risk factors such as age, obesity, and past medical history, surgical history, because of the knee repair that she had. And on top of that, she does have a sedentary lifestyle. Most likely, this is her diagnosis. Another differential for her is going to be rheumatoid arthritis, which is an autoimmune disease known by symmetric joint prolonged morning stiffness that lasts more than 30 minutes. She doesn't have anything such as the systemic symptoms that this RA will present with, which she will be a low-grade fever, weight loss, or fatigue. Additionally, we would need to do further testing too for this, such as the RF, anti-CCP, ESRP, and CRP. And lastly, we have GAL, which is an inflammatory arthritis with acute severe joint pain, redness, and swelling, typically affecting the first metatarsophalangeal joints, but can involve the knees. Also, further testing will be needed for this, so we will need to get the serum uric acid levels. So most likely that the final diagnosis for this patient is going to be osteoarthritis. And for this, we're going to obtain a bilateral x-ray of both knees to evaluate the joint space narrowing and osteophytes and subchondral sclerosis. We also need a ESRP, a CRP, ANA, and RF to rule out inflammatory arthritis. We also need a serum uric acid levels to assess for gout. And lastly, we will need a serum creatinine levels to ensure that NSAID safety. NSAID is safety for us to use since she has a history of CKD. Pain control, we will also give the patient Tylenol or acetaminophen 1,000 milligrams, PO every 6 hours, PRN, with a maximum dose of 4 grams a day. Topical diclofenac gel for the localized pain, and also knee brace for joint support. Patient needs a couple referrals. The first one will be in orthopedic, just because we want to manage or have them further for further OA management, endocrinology for diabetes and blood glucose control, a nutritionist for weight loss and improved dietary habits, and physical therapy for personalized exercise plan focused on quadriceps strengthening and joint mobility. Lifestyle modifications such as a weight loss program to reduce the joint load, Mediterranean diet that should be rich in anti-inflammatory foods, and a low-impact exercises such as aquatic therapy or cycling. Patient education. Patient needs to understand that osteoarthritis is a degenerative disease and symptom management is the key. Also emphasize on blood pressure and blood glucose control to reduce the inflammation, and encourage the blood pressure to be anything less than 140/90 per ADA guidelines, and also the importance of medication adherence and physical therapy. We will lastly see this patient in 2 weeks as a follow-up to review the results of the test and reassess symptoms. Also for us to monitor pain control, blood glucose levels, and the blood pressure. Thank you so much, guys, for watching my presentation.